Right. So as you said, my name is Kayla LeMarbe, and I'll be presenting my quality improvement project about a continuing education module that I developed regarding trauma-informed pain management in labor and delivery. This project was conducted through the University of Michigan, and I was assisted by Dr. Yasmin Kusnoki, Dr. Julia Sang, and Dr. Mickey Sperlich. Just as a disclaimer, this presentation does discuss trauma, PTSD, birth trauma, and it can be triggering. So if anyone feels like they're overwhelmed or they feel uncomfortable, please feel free to step out at any time. For some background about the prevalence of this issue, in the perinatal population, 50% of women in the United States suffer at least one traumatic event in their lifetime, and 20% experience sexual abuse. Women are also more likely, about 2 to 3 times more likely to experience PTSD. PTSD affects about 8% of pregnant women. Postpartum PTSD affects 3 to 6%, but it can be as high as 16 to 19% in those with risk factors. That would be something like a prior traumatic birth experience, pregnancy complications. Anxiety, fear, anticipation of pain, and PTSD, plus prior traumatic experiences can all influence the perception and intensity of pain, reduce someone's pain tolerance and pain threshold, and should be addressed when discussing pain management in labor. Patients with PTSD also report higher levels of pain and increased susceptibility to pain-related problems. Anxiety specifically increases the risk of post-traumatic stress symptoms. The lack of discussion and continuing education opportunities on trauma, PTSD, anxiety, and depression are a highly prevalent problem in the perinatal population, the treatment of which is only recently gaining momentum in healthcare education. Labor and delivery nurses are the ones who spend most of the time at a patient's bedside when in labor, so it's vital that nurses know what trauma-informed practices entail, how they apply to pain management, and how to tailor specific interventions to meet the needs of a trauma survivor. Prior to starting this project, I searched different continuing education databases and found no reports or organizations offering continuing education opportunities specific to PTSD and trauma-informed labor pain management. So this was a significant gap in peripartum care and education. The main goal of my quality improvement study was to create a continuing education module for labor and delivery nurses to address this gap in education and increase labor and delivery nurses' knowledge, attitude, skills, and use of trauma-informed care and pain management in labor and birth. Before creating the continuing education module that was implemented in the study, I conducted a literature review to examine commonalities and preferences identified by trauma survivors regarding their perinatal, intrapartum, and postpartum care. This research and information was then incorporated into the education module. So a couple of the common themes and components of care, one of them was control. Control was a very important aspect of perinatal care and care during labor and birth for survivors. Loss of control can lead to re-traumatization or be a trigger for a lot of survivors. Ways that both providers and labor and delivery nurses can allow the birthing person to maintain control would be providing privacy, choice, personalized decision-making, and autonomy throughout their care. Maintaining a sense of control can also be achieved by making a birth plan, controlling how much of their body is exposed, and acknowledging that they have a choice regarding cervical examinations. Presenting survivors with options and choices throughout their prenatal care, labor, and birth will dramatically increase their sense of control, power over their own body, and their pregnancy and birth. Disclosure of trauma history was another common theme for care. Survivors reported that they want their obstetrical care provider to be aware of their trauma, but disclosures often can be triggering, and they can end up reliving those traumatic experiences when disclosing. Survivors also noted that timing of disclosure, having a trusting relationship with an empathetic provider that maintains their confidentiality was also important when deciding whether or not they wanted to disclose. Dissociation is another common theme, and it's defined as the disruption of and/or discontinuity in the normal integration of consciousness, memory, identify, emotion, perception, body representation, motor control, and behavior. Some survivors view dissociation as a coping mechanism, a way to actually separate their pain of their past trauma to the labor pain, while others felt that it was a form of surrender and a loss of control. Finally, the last common theme that survivors noted in the research was that they desire more education and resources on coping strategies during their prenatal care. One study found that 51.7% of their participants would have found it helpful to have been provided with coping strategies for their trauma before they had their baby. Half of participants in another study also desired a team approach for mental health care and trauma-informed care. Research has shown that there's a significant association between pain in labor, overall birth experience, and post-traumatic stress symptoms. Adequately controlling pain in labor could significantly reduce trauma and PTSD associated with childbirth, as well as greatly reduce the potential for worsening PTSD in people with a previous trauma history going into labor and birth. One study examined the relationship between early administration of morphine or nitrous oxide and PTSD development in the context of childbirth. The results demonstrated that nitrous oxide administration during childbirth predicted milder childbirth-related PTSD symptoms, and lower reported pain scores overall in labor also predicted the absence of childbirth-related PTSD symptoms. It's important that obstetrical care providers understand that while labor and birth is painful, management and decreasing the person's perception and severity of the pain will improve the overall birth experience, and it's a very important component to trauma-informed perinatal care. So as the literature shows, trauma is highly prevalent in this patient population, and it is well known that pain increases distress, anxiety, hinders coping, increases the risk of traumatic birth experience and development of PTSD after birth, or possibly worsening pre-existing PTSD. Anxiety is heavily prevalent in labor and birth, especially in those with a trauma history, but also in those without. And treating anxiety can play a large role in management of PTSD symptoms, especially acute. So management of anxiety is a very important component of labor pain and could reduce the incidence of childbirth-related PTSD. However, treatment of anxiety is often missed in practice, so this would be something to work on implementing, such as utilizing tools like nitrous oxide or other anti-anxiolytics for anyone demonstrating or verbalizing anxiety about labor or about the labor pain. There are also trauma-specific interventions that can be implemented for survivors that choose to disclose to their perinatal care providers, such as recognizing signs of dissociation during labor, which would be narrowing of attention, becoming very quiet all of a sudden, time distortion or losing time, and confusion. Discussing known triggers with your clients or birthing persons and how to avoid them. So this would be like if they have specific words or phrases, bodily positions that would be triggering, and choosing pain modalities tailored to their exact needs. So for an example, if someone needs to have a lot more control over their environment and their own body to avoid re-traumatization, then an epidural might not be an optimal choice. But on the flip side, for someone who, if they feel any pain, it's a trigger of their past trauma, an epidural would probably be the better pain modality to implement early on. There could be a situation in which that the survivor has chosen not to disclose to anyone on their perinatal care team as well. But there are general trauma-informed care practices that can be implemented in labor for all birthing persons. This would be simple things like ensuring and maintaining privacy, limiting the number of people in and out of the room, keeping the person covered, talking at eye level, knocking and waiting for permission before entering a room, and then waiting for explicit permission and consent before doing any sort of exam, but especially cervical exams. So moving along to the actual project, a continuing education module was created and distributed to labor and delivery nurses on a single intrapartum unit in Michigan. This module was developed over the course of 4 months and approved for 1.5 continuing education hours as an incentive for participants to complete it. The module itself was written by myself and an expert in the field of trauma-informed perinatal care, Dr. Julia Sang. The first section of the module went over trauma, anxiety, the pathophysiology of PTSD, and how those factors all affect pain and why it's relevant to labor and delivery. Section 2 of the module reviewed the 6 key principles of trauma-informed care. Those are safety, trustworthiness, and transparency, peer support, collaboration and mutuality, empowerment, voice, and choice, cultural, historical, and gender issues. And then the 4 R's of a trauma-informed approach, which are realization, recognition, respond, and resist re-traumatization. It also, this section also reviews specific concerns that trauma survivors have for their labor and birth experience that we had discussed in the literature review section, like control, disclosure, dissociation. And then the last part of section 2 includes key practice recommendations for how nurses can perform specific assessments and avoid triggers or re-traumatization for survivors. Section 3 of the module discusses how to approach labor pain management in a trauma-informed way, what trauma-informed consent looks like, and how to offer patients in labor pain management interventions in a trauma-informed way, as well as how to follow up with survivors after birth. So participants completed the pre and post module surveys from November 30th, 2021 to January 26th, 2022. It was an online format that allowed the participants to complete the pre-module survey first, then directed them to complete the education module, and then it took them through the post-module survey as well as a 10-question multiple choice quiz. The surveys assessed knowledge, skills, attitudes about trauma-informed care, and nurses' opinions on the importance and relevance of this topic to their clinical practice. The Knowledge, Attitude, Skills, or KAS survey model was previously field tested and constructed in alignment with Knowledge, Attitude, and Practices Framework and Measured Development Guidance. In a larger pilot study, not this one, but a larger one where it was field tested, it had an internal consistency alpha of 0.78 at pretest and 0.85 at post-test. 4 weeks after the participants completed the pre-module survey, the module, and the post-module survey, a follow-up message was sent to evaluate the use of the skills in clinical practice after the education module. A comparative analysis between the pre- and post-module surveys was done using the Wilcoxon-Sign Rank test to determine differences in knowledge, attitude, and skills before and after the education module. A content analysis was then used to analyze the open-ended questions that we had from each survey as well. So for the sample characteristics to get an idea of the participants, a total of only 17 participants completed both the pre and post module surveys. Of those 17, the majority, about like 35%, were 46 years older and above. The remaining age categories were pretty much evenly distributed, with the second highest category being ages 36 to 40 at 23.53%. Over 80%, 88.23% to be exact, of the participants had at least 3 years or more of nursing experience. And 64.71% of the participants reported that they had never taken a continuing education module specifically regarding trauma-informed perinatal care in labor and delivery. So this means that the majority of the participants were not novice nurses, and in the years of their nursing career, they had never taken or been offered a CE course or education on this topic. So using the Wilcoxon-Sign Rank test, change in knowledge, attitude, and skills from before and after the intervention were evaluated. Change in both knowledge and skills were both statistically significant, but there was no change in attitudes from before or after the education module. For an example of some of the specific questions on the surveys that also had statistically significant change from pre and post module, one of them was, I feel confident in my understanding of trauma-informed care. I know how to identify PTSD and dissociation symptoms in clients. I know how to address survivors' potential triggers and offer pain management in a trauma-informed way. One of the short answer survey questions that we asked in the pre-module survey was about what barriers do you perceive will hinder your ability to implement this knowledge from the module? Not all the participants answered those short answer questions. Many did end up skipping them, but I have noted a couple of the responses here. One of the respondents had a pretty good involved response about how they've experienced their own types of trauma related to childbirth, and they know that it's not going to be the same for everyone. Like the trauma they experience won't be the same as what someone else is going through, but they felt like this was a good place to start. And then the next question related to barriers was asked in the post-module survey, and it was about what ended up being a barrier to completing the module or finishing the module in surveys. And the participants had stated that because the module was online, it wasn't as engaging as it could have been in person, and that the module was a little too long. Finally, one of the last short answer questions asked in the post-module survey was if the module met their personal objectives. The responses were overall positive. They mostly said that the module was very useful. It touched on topics that they might not have felt as skilled in before, and that the examples we had used in the modules and case studies that we had given were very helpful and informative. 4 weeks after the intervention, a follow-up survey was sent out just to the 17 participants that completed both the pre and post-module surveys. Only 3 out of the 17 participants responded to the follow-up survey, but all 3 said that they have used and will continue to use trauma-informed care and pain management techniques in their clinical practice that was taught in the module. So overall, the continuing education module was effective at improving knowledge and skills regarding trauma-informed care for labor and delivery nurses. The lack of change in attitudes may have been attributed to the site of the intervention and that the institution itself already promoted an environment that encouraged trauma-informed care, and they were seeking out a continuing education module regarding trauma-informed practices. Prior to the implementing the module, it was originally thought that a facilitator for this project would be that the module was asynchronous or online, so participants could complete it at their own pace, but that did not end up being the case. The primary response was that because the module was asynchronous or virtual, and the lack of in-person teaching ended up being a barrier and inhibited their ability to ask questions and fully engage in the education and comprehension. Even though there were only a few respondents to the follow-up survey, the responses were promising and indicate that those nurses who did respond plan to continue to use the knowledge and skills from the module in the future. There were a few limitations to this project. First, the inability to perform an on-site visit due to the unit having some staffing issues and the COVID-19 pandemic just at the time. Burnout, staffing issues, and other stressors going on might have also contributed to the lack of follow-up responses and the smaller sample size of only 17 participants. All of the nurses for whom this education module would be applicable were likely not all reached, so that could be something in the future done. And then an on-site visit also could have led to less of a report of the lack of in-person teaching being a barrier, as the project director myself could have followed up in person with some of the participants to answer any questions or, provide any clarification. So what does this mean long term? More continuing education opportunities about trauma-informed perinatal care and trauma-informed pain management are definitely needed to improve knowledge, attitude, and skills of healthcare team members who provide care to survivors in labor, so not just nurses. But while nurses are the primary caregiver present at the bedside, it is vital and very important that their knowledge and management makes a big difference in a survivor's birth experience. And this nursing education is a really important first step in reducing survivor re-traumatization in labor and birth, as well as reducing the instance of PTSD related to childbirth for all birthing persons. These are some of the references just from the literature review, the module, and just throughout the implementation. And that is my email, usually the best way to get in contact with me if anyone has any follow-up questions or anything, but any questions right now that I can answer?